All right, here we go. Chapter 9, Part 3, Vital Sign Measurement and Obtaining of our Patient's Vital Signs. We have already practiced here in class on obtaining vital signs, checking pulses, respirations, blood pressure, pupillary response, skin color, temperature, and condition. We're not going to really go over documentation of vital signs just because I have absolutely no idea once you guys hit the road what you're going to use for your documentation software. So that'll be something that either down the road, if you guys have questions about some stuff, you could always send me an email, or somebody's going to be responsible for, I imagine, the whole online portion of your documentation software. So hopefully there's an in-house expert, because all of these computer programs that we use to document patient encounters and write narratives and do our run sheets and stuff are all a little bit different. Then we will get into the use of monitoring devices for our vital signs. Now, we've talked a little bit about pulse oximetry and automatic blood pressure cuffs and stuff like that. And sure, tools like that, do they have a place? They sure do. But you can't ever really argue with the idea of getting back to basics and actually performing the skill. That's why we're practicing so much taking blood pressures in the beginning of every class, because it is a skill and it is something that we need to be able to rely upon. When we went over drugs, you learned pretty quickly that giving someone who doesn't have a blood pressure high enough to support it nitroglycerin is going to have negative consequence. It is going to have a poor outcome. And it's just, we need to be able to take a blood pressure, get those numbers, the systolic and the diastolic, and really be confident in the fact that we were right. Moving forward even a little bit deeper than that, when you guys are actually working on patients and you find somebody who's sick and would benefit from a paramedic working on them, there's medicines that a paramedic can and can't give based on what we tell them for the patient's vital signs. They show up, and a lot of the times they will rely on the numbers that we're going to give them in regards to what they should and shouldn't medicate a patient with. So keep in mind that it's not just for your treatments, it's also for what other members of our integrated care team may provide as treatments to these patients. So why are vital signs important? They are outward signs of what's going on inside. We've talked at length now about all of the processes and all of the things that are going on inside of our patient. Well, our vital signs are really something that gives us an ability to quantify and measure those things and really give us a sneak peek at how well those things are working. Now, when I first introduced you guys to vital signs, I talked about trending and identifying trends in our patients' vital signs. What exactly am I looking for when I talk about identifying trends?
Any changes from baseline?
Yeah, changes from baseline. That first set of vital signs I take, and this is something that we'll talk about a lot going forward as well. That first set of vital signs I get from my patient is what I would call my baseline set of vital signs, because I don't have clue number one what that patient's blood pressure, heart rate, respiratory rate, pupillary response, or any of that stuff is normally. So this is my very first peak, my baseline initial set of vital signs. And everything I do from there on out is just going to compare what my initial was to what I have right now and which direction is my patient going. Did I not provide any treatment and I can see my patient's vital signs worsening, either getting a lot higher or getting a lot lower, and my patient condition is not improving? Or did I provide some treatment, now we'll say with nitroglycerin or epinephrine, and I've seen some improvement with my nitro. I've seen the blood pressure come down a little bit. I've maybe seen their skin color, temperature, condition improve some. Or my epinephrine. I've given some epinephrine. Now I'm taking a subsequent set of vital signs trying to trend my patient's condition again to see, did my patient's blood pressure come up? Did their mental status come up? Did some of the skin signs that I'm seeing begin to improve? And my patient's getting better. You can take out the gathered on virtually every EMS patient. We will gather vital signs of some form or fashion on every single patient that we encounter, even the ones who are non-compliant and a real pain in the neck. There are things that we can do, think like respiratory rate and skin color, temperature, and condition, even on people that don't want us poking and prodding, don't want us touching them, we can still obtain some form of vital sign on everybody. So our comprehensive list here of vital signs is going to be pulse, respiration, so heart rate and respiratory rate, skin color, temperature and condition, and capillary refill time. Capillary refill is if you take your patient's fingertip and you pinch their nail bed, you'll see that that nail bed will go white when you pinch it. You're actually forcing all the blood out of those capillary beds with that pressure. When you let it go, it should return to pink within 2 seconds. That is a normal capillary refill time. Oh, hang on, we're getting something in the chat here. Eric, give me just a second, I'll take a look. All right, so blanch out the nail bed. If it takes longer than 2 seconds for that nail bed to go back to pink, that means that perfusion is lacking. That means our patient is not supplying blood as rapidly and as briskly as we would like to see down to the peripheral of their body. If we have an extended capillary refill time, we know that the transport of oxygenated blood is not getting out to points far and wide when we see that. Now, as far as how accurate and how useful is capillary refill, it's kind of hit or miss. Sure, is it a quick down and dirty way to take a look at something? Yes, as a matter of fact, it is. But looking at all the rest of the vital signs, things that we can actually quantify and put a number to, are really going to put much more emphasis on our patient condition. Because what that capillary refill is really sort of depicting for us is blood pressure, heart rate, respiratory rate, skin color, temperature, and condition. It's really sort of kind of much more of a bird's eye view. Pupillary response is another one. Pupillary response is going to show us neurological function and are the nerves controlling things the way that they're supposed to. And then last but not least, we're down to blood pressure. Somebody out there tell me, when I'm measuring my patient's blood pressure, what exactly am I measuring? Does anybody remember?
Systolic and diastolic.
Okay, systolic and diastolic. That systolic number is the amount of pressure that the heart has to overcome to squeeze blood out. That is when the heart actually contracts and ejects blood from the ventricles and gets it out into circulation. That's how much pressure is on the artery walls when the heart is ejecting blood. That diastolic is how much pressure is left in this entire system when everything is relaxed and refilling. So systolic is the squeeze. Diastolic is when our bucket's filling back up. Our baseline vital signs, first set. Remember, we don't know these people from a hole in the wall. So we have no idea what their heart rate is at rest normally, what their blood pressure is normally, what their respiratory rate is normally, what they normally look like. What we measure when we're measuring that baseline set is that patient versus what is called normal. Now, our typical normal blood pressure that we talk about is 120/80, right? That's the measuring stick. That doesn't mean that somebody who's got a blood pressure of 138/86 is dangerously sick. Because when we look at our vital signs, we also need to look at our patient history. Does my patient have a history of high blood pressure? Does my patient have a history of type 2 diabetes and maybe, some recent weight gain that has made things sort of have to work harder? So their blood pressure is a direct sort of result of the fact that maybe they're a little heavy, or maybe, their medication isn't working quite as well. Vital signs are really just a snapshot. We repeat our vital signs and establish our trends because we're looking for more information. I'll tell you, when I do an assessment on a patient, I am an absolute information hog. I'm like a sponge. I want to know everything, because the more information I have at the tips of my grubby little fingers to try and figure out what's going on with my patient, the better I'm going to be able to put my picture together and figure out actually what is going on with my patient. Now, when we talk about patient assessment, I'm going to tell you there are times where you're going to have interactions with some people, and they're going to give you the most non-specific of non-specific complaints, and you're going to walk into the emergency room, and when they ask you what's going on, you're going to shrug your shoulders and go, I have no earthly idea, but this is what the patient told me, and this is what I found. And that's perfectly acceptable. And there are other times where their condition is just going to hop right up and hit you on the head with a stick, like our asthma patient, when we hear those expiratory wheezes as we're approaching. We didn't even touch the stethoscope yet, and we can see them working hard to try and breathe, and we can see an increased respiratory rate and an increased heart rate, and add that together with the history of asthma and 2 + 2 being 4. Okay, we got called for a respiratory complaint. I hear audible wheezing as I approach. I see increased respiratory rate, rhythm, quality, and effort. None of those things are good. And I have the expiratory wheezes to confirm my suspicion that my asthma patient with a respiratory complaint is suffering from some form of asthma problem. It is a little from column A, a little from column B. Sometimes the problem is right there in front of you. It's like on a T, and all you have to do is hit it. Other times there's some digging and some investigation, and we still may have, like I said, no earthly idea what the problem is. Pulse is the actual palpable pressure of the heart beating. Every time that left ventricle squeezes, it causes a wave of blood to move through the arteries. Now, most of the time those arteries are full, so it doesn't actually look like a wave. That's why you can feel the actual palpable pressure. The arteries being filled with blood, when that left ventricle squeezes, that pressure just pushes against the walls of those arteries. And that's why when we put our fingers on the radial pulse or carotid pulse or anywhere else that we're going to check a pulse, we can feel that pressure wave. It is corresponding directly to when the left ventricle squeezes. Anywhere that an artery goes over a bone and it is close to the surface, we can check a patient's heart rate. So riddle me this. How long are we going to check most patients' heart rates for? How long are you going to put your fingers over that pulse point and check their heart rate for?
15 to 30 seconds.
15 to 30 seconds. So if I check it for 15 seconds, how do I get what their heart rate is over a minute?
Multiplied by
Times
4.
4.
All right, good. Now, let's say my patient's heart rate is either really, really fast or really, really slow or quite irregular. How long should I check their heart rate for?
60.
About 3.
Yeah, the whole minute. Good. So normal for a heart rate is what we call between 60 to 100 beats per minute. So if our patient's heart rate falls between the number of 60 and 100, we're going to say that their pulse is within normal limits. If my patient's heartbeat is over 100 beats per minute, we're going to call that tachycardia. Let's take a look at the word while we got it up there on the screen. We have tachy. We know what tachy means?
Rapid or fast?
Rapid or fast. And then what does the end portion of this word look like?
Cardiac.
Yeah, it looks like heart, cardiac, right? So really at its basic level, fast heart or rapid pulse. If my patient's heart rate falls below 60 beats per minute, we are going to call that, as a general rule, too slow. And if my patient's pulse is too slow, we're going to call that bradycardia. So we look at the word. Brady means slow. We have the same ending, so we have slow heart means slow pulse or not enough beats per minute. So 60 to 100 is really what we're looking for. If we find a patient who has a heart rate of above 120 beats per minute or below 50 beats per minute, we're going to call that a serious finding. Generally speaking, a resting heart rate that is either way, way fast like that or really, really slow like 50, unless our patient is either in the middle of a pretty significant workout and has a heart rate of 120, because that's obviously then not resting, or my patient is, a marathon runner or some form of really in shape professional or even amateur athlete who just, doesn't require as many beats per minute to supply oxygenated blood, we're going to call that a significant finding. We're putting all of these pieces into our puzzle. One thing really rarely is ever something that we just point at and say, that one thing right there is terrible. My patient looks great, but that one number is awful. If we were standing at the starting line of the marathon and running around taking blood pressures, we would probably find, not blood pressures, pulses. We would probably find a lot of people who had heart rates below 50. Not really a pathologic finding at that point. These people are preparing to run 26.2 miles. They're in good shape. Their body doesn't have the same demand as someone who's not in quite as good a shape. So look at all of these. Whenever you hear the words normal, look at everything sort of with a grain of salt. See how it fits together with your patient presentation. So this should all look pretty familiar. When we were talking primary assessment and we were talking about the C in ABC, our circulatory, we were looking for rate, rhythm, and quality. So we've already talked about rate. Now we have rhythm and quality. What we're looking for here is how regular is my patient's pulse. The rhythm is going to tell me, are there regular intervals between beats? Are they nice and constant? Is it marched out? Because that's the way the heart's supposed to be. Doom, 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 doom. It's not supposed to sound like somebody's playing a drum solo in their chest. If we are checking our patient's pulse and we find that it's very irregular, it's very erratic, that's going to be a significant finding until proven otherwise, because we don't have cardiac monitors on BLS ambulances around here. It's going to be something that until either a paramedic or a doctor in the emergency room can look at that irregularity and say, this is normal, maybe this is weird, we're just going to call it weird. If we find an irregular pulse, that's problematic as far as I'm concerned. Force looking at quality, we're talking about how does it feel? It should feel nice and strong. When I had you guys checking pulses and reaching around and checking your own pulses, I don't think anybody probably thought that it was, kind of puny and weak and difficult to find once you got your fingers on it. When we find a pulse that is thready like that, it means the pulse is weak. It feels thin. It's hard to even tell, can I feel something? Can I not feel something? That again is an abnormal finding. If you're having a hard time locating or keeping your finger on that patient's pulse because it just feels like it's going away, what do you think is going on?
It's not getting enough blood pressure, enough blood.
Bingo. We don't have enough pressure in the system for one reason or another. We have no earthly idea what that reason is at this point. But what we know is for one simple second, when I feel that pulse, the pressure dips. Now I got to figure out why, and I have to figure out what's going on. But just by putting your hand on the patient's pulse points, we absolutely can say, that's kind of odd, right? That should feel equal all the time. It should feel nice and strong, and it should feel nice and regular. And if we find problems with that, we know that we're getting towards the neighborhood of things aren't regular. So we have radial, brachial, and carotid. Where do we check a radial pulse?
Where your wrist or your watch is.
Yeah, where your wrist or your watch is. Thumb side or pinky side?
Thumb side.
Thumb side. That's the radial artery. It goes over the radius bone in your forearm. What about a brachial? Where are we checking a brachial pulse?
Yeah, the bicep.
Near the bicep. Who do we normally use that on most of the time?
Children, infants.
Children and infants. Good. And last but not least, carotid.
Right near the neck.
Right near the neck. Has anybody had a hard time finding that?
No.
No?
Probably the easiest ones to find.
Yeah, because it's the strongest and it's really kind of close to the surface.
Correct.
Yeah, if you guys are having any trouble with any of those, let me know, because that's part of the reason we do vital signs, because it's weird and kind of handsy and one of those things that practice makes perfect. So moving right along, we'll talk respirations. So respirations is the physical act of breathing in and out. We're measuring rate, rhythm, and quality here again. Our respiratory rate, easy enough, is how many breaths does my patient take in? What is going on here? How many breaths does my patient take in 1 minute? Pretty simple. Same thing. We're going to count for 15 seconds. We're going to multiply by 4. If we're seeing some irregularity or my patient's respiratory rate is excessively fast or excessively slow, not only am I going to have to do something about that, I'll probably have to count it for a little bit longer than my 15 seconds. Remember, if you only count for 15 seconds and multiply by 4, every heartbeat or every breath that you miss gets multiplied by 4. So if something odd is going on with your patient's heart rate or respiratory rate, you're better off counting for longer, trying to make sure that we're getting everything right. Normal respiratory rate for an adult, 12 to 20 breaths per minute. Remembering that the body doesn't really do anything extra that it doesn't have to. If 8 breaths a minute was enough, our patient would only breathe 8 times a minute. 12 to 20 as far as respiratory rate goes is pretty much standard across the board. Sure, does age, sex, size, physical condition, emotional state all influence that? Absolutely. If you show up and your patient is in the middle of a full-blown panic attack, expect that their respiratory rate will be well over 20. But these things are self-correcting. Remember, our respiratory rate and all of that is controlled in our brain. We have all of those chemoreceptors and the pneumotaxic centers inside the brain that are going to slow that back down. If it's not a pathological thing that is making this patient breathe fast, a respiratory rate doesn't stay fast. A respiratory rate doesn't stay slow unless something else is going on. If our patient has a respiratory rate greater than 24 breaths per minute or less than 8 breaths per minute, this is potentially one of the more serious things that we will find when we evaluate a patient's respiratory rate. Why do you think that might be? Why are weight of more than 24 or 8 or less pretty significant?
I would say both ways. They're not actually taking in a deep enough breath to get enough oxygen in and get that good diffusion. Because if they're breathing too fast, I guess that would indicate shallow breaths. And if they're taking 8, that's not enough breaths per minute.
Right. No matter how deeply you breathe at 8 breaths per minute, you're still bringing in way less oxygen per minute, which is, you're exactly right. It's going to create a problem with diffusion because more than 24, we're talking really, really rapid, but really, really shallow breaths. So not all of those alveoli are getting filled up. And if not all of those alveoli are getting filled up, we're going to have a problem with diffusion. If we're only breathing 8 times a minute, sure, we might be filling those alveoli, but we're filling those alveoli with only like 3/4 of the amount of oxygen we're supposed to. The body needs what it needs, and it needs it when it needs it, which is all the time when we talk about oxygen. So either of these two things right here, greater than 24 or 8 or less, is going to be a fairly significant issue that's going to need our full undivided attention. What do you think we have to do for somebody who's breathing 24 or more times a minute or 8 or less times a minute generally?
Supplement oxygen.
Mono
Supplemental oxygen probably works some of the times especially with the too fast. You know, we can supply them a little bit of oxygen, their body starts doing the right things because now they have extra oxygen available at least, and maybe the respiratory rate slows down some. But what's something else we might have to do, say, for somebody who's breathing 8 times a minute or 6 times a minute?
Ventilate.
Yeah, we'll ventilate them. 1 breath every 5 or 6 seconds with that BVM to provide for them the supplemental oxygen, because they're not taking in enough breaths consistently enough to actually bring in enough gas for this to even be workable. So what we need to do is provide them that gas with some positive pressure ventilation for the BVM and use the BVM to force that 100% oxygen into them.
Are you able to ventilate for someone who's breathing rapidly?
Yeah, we will actually talk about that today, because before times of COVID, when, breathing on people didn't get you a felony, I used to let everybody ventilate me with the BVM, because ventilating someone who's breathing too slow is easy. A respiratory rate of 6 times a minute is 1 breath every 10 seconds. That means you have 10 seconds to get another breath in. Someone who's breathing 24, 30 times a minute, somewhere in there, that's a breath every other second, and it's a little more difficult. But there are some tips and tricks to make that a bit easier, and we'll talk about that today. So when we look at respiratory quality, we only have a few choices here. We have normal, we have shallow, we have labored, we have noisy. So normal's pretty simple, right? Looks regular rate, rhythm, and quality, noiseless, effortless, and painless. Shallow, we already covered too. If somebody's barely moving their chest wall at all, and we don't see that good movement of their chest when they breathe, we know that almost all of that gas is staying in what we call the dead space. None of it is getting down to the alveoli, and if it doesn't get to the alveoli, it's not available for diffusion. We don't have that gas moving from high concentration to low concentration, and we wind up downstream with hypoxia. We wind up with cellular hypoxia, and we wind up switching from aerobic to anaerobic metabolism just based on the fact that all that gas was staying in the dead space because of that shallow respiratory effort, and our patient is going to have some significantly negative consequences and outcomes from that. So in staying under the idea of noiseless, effortless, and painless, let's talk about labored breathing. What do you think constitute labored breathing? Now, I'm not looking for conditions. What to you would be something that would trigger you to think somebody was breathing laboriously and it was just a lot of work?
Those accessory muscles.
For sure. When you start seeing people flexing like they're in front of the mirror in the gym just to get gas in or get gas out, that's a problem.
Maybe they're not able to talk that much.
Okay, yeah. They're not able to talk because they're using all of the available oxygen they have to support metabolism. And having to speak to you or speak to anyone else is wasting gas that they need to continue being a human. So maybe one, maybe two words, maybe just nodding of the head, because their breathing has become so much work and has demanded so much energy that doing anything other than breathing is just too much extra effort.
The flaring of nostrils. Right?
Absolutely. When we start to see those nostrils flaring out and, you know, getting really big and wide, trying to accommodate bringing more gas in, for sure. Good, good, good. And then last but not least, we're going to get to noisy breathing. Breathing should never be noisy. If we hear noisy breathing, what are some of the things that we're listening for?
Like wheezing, crackles.
Okay. Couple more. Give me a couple more.
Strider.
Bronchi, stridor, perfect. So all of the things that we've been listening to the dummy and kind of working out, those are things that are going to point me towards not only specific respiratory conditions, but they are also going to tell me, is my patient's respiratory rate, rhythm, quality, effort, call it what you want, some combination of all of those, is it enough? Can I look at it reasonably and say, they are doing this well enough that maybe I just provide them some oxygen and we go? Or are they not really doing this well enough at all and I need some pretty significant intervention? This is one of my favorite. Skin color, temperature, and condition is absolutely something that, as a provider in the field of emergency medicine, is one of the best things you can evaluate on your patient. You don't even have to touch them. It's not invasive at all. It is really just look at your patient and say, is this patient adequately circulating blood to the everywhere? And if you look at your patient and they're pink, warm, and dry, guess what? They are. Now, that doesn't mean that they're not sick. That doesn't mean that there's not something significant going on with them. What that is telling you right then and there with just looking at them is a pretty good idea of sick versus not sick. Now, sick versus not sick is weird when you hear it put in that context, but sick versus not sick means, we'll take sick first. Sick is the patient that you look at and go, man, why couldn't somebody else have gotten this call? This patient is failing. This patient is not well. Not sick means, all right, this patient has a complaint. There is something clearly wrong with them, but I don't think they're going to die in my ambulance. That's really at the base of it, what we're getting into when we talk about sick versus not sick. Sick means you look at the patient and go, boy, they're going to be a handful. I better be on my game. Not sick is the patient you look at and go, there's still something wrong with them, but hopefully we got here in time. And it doesn't mean that they're going to remain stable the whole time. It doesn't even necessarily mean that they are stable at the moment. But your first interaction, that sort of gut feeling when you look at them and you go, ooh, pale, diaphoretic, not looking so great, doesn't look like they're circulating blood very well. Crap. Or your patient who's pink, warm, and dry, and you go, all right, well, their heart is still able to pump blood out to the everywhere. You know, they still look like they are perfusing. Because when perfusion starts to fail is when everything starts to fail. When perfusion is still going well and your patient is adequately circulating that blood and adequately circulating that blood to places that are arguably less important, like their nail beds or, you know, the inside of the cheek or underneath the eyelids, and we can see all of these peripheral places that are still pink, warm, and dry, you look at them and you say, all right, well, their body is still adequately perfusing itself. It is still at the point where it's not starting to move blood away from things that it doesn't care so much about. That patient is less sick. Does that make sense?
Yep.
It all goes right back to gas exchange, perfusion, and metabolism. If we can't exchange gas, sick patient. If we can't perfuse all our tissues, sick patient. If we can't create energy, sick patient. And really, our vital signs are very much helping us to measure those things. When we measure our patient's pupillary response, first thing we're going to look at when we look into our patient's eyes is going to be without the pen light. We want to get a look at what the baseline size is. We want to know how big this pupil is just normally sitting there. Then we will cover that one eye, gloved hand over the eye, and we use our pen light and we shine it in the patient's left or right eye respectively, and then we remove the light. What you should see when you shine that light in your patient's eye is the pupil should constrict and then it should dilate. As soon as you remove the light, it should flash right back open. And the same thing should happen on the other side. If we see that at baseline, our pupils are what we would consider normal. You know, the patient's eyes aren't doing anything funky. We don't have one pupil that's really big and one pupil that's really small. If our pupils look equal, round, and reactive to light, we're going to call those equal, round, and reactive to light. That's how you would document it. If you look in your patient's eyes and they aren't the same size, and I don't mean exactly the same size, sort of closely the same size, that is something that we're going to have to document. That is something that we're going to have to consider as a significant neurological finding until it's deemed otherwise. Generally, I mean, probably way more of the population than not, pupils are all going to be close to the same size. Pupils are all going to have the exact same response to when we shine light in them. They're going to constrict and dilate appropriately. It's going to be nice and rapid, and we're not going to see altogether that many problems. if you look in your patient's eyes and they are constricted, tiny little flecks of black when you look at their pupils, that's going to be part of what we use as our assessment, especially if we think this is an opiate overdose. Because one of the things depressants will do, and opiates are a central nervous system depressant, is they constrict pupils. They make them really, really small. Other times, we'll look in a patient's eyes and it will look like the iris, the colored portion of their eye, is nothing but pupil. That's how mine looked on Friday. Different things will point us towards different conditions. If we have dilated pupils that don't respond when we shine light in them, or we have very, very sluggish pupils, or patient who's got a head injury, we may see, since we have neurological issues going on, we may see pupils that don't respond quite the way that we expect them to. And if they don't, it's a finding. It doesn't always mean that there is something huge and awful and negative happening to this person. What we want to make sure that we're on the lookout for is differences. You know, if we have pupils that are different size, are unequal, they don't react appropriately. Those are what we're looking at when we shine a pen light in our patient's eyes and check their pupil response. Under ordinary conditions, pupils will be right in the middle of the eye. They will constrict and dilate appropriately, and it will normally be pretty quickly and very, very equal. It seems very unremarkable when you shine a pen light in somebody's eye and it does the thing that it's supposed to. When you look in somebody's eyes and you're assessing their pupils and we see things like this, that's a bit more remarkable, wouldn't you say? You know, we look at our constricted pupils and you see that there is hardly any pupil there at all. It is almost all brown eye. Or we look at our patient with their dilated pupils and it is almost all pupil and no brown. Most people's eyes don't look like this. And then of course you have unequal. Unequal means one side of the brain versus the other is having something fairly negative happen to it. Now add to the fact that if my patient is on some form of central nervous system depressant, depressants have a pretty good ability to turn things off. So my patient with their constricted pupils, and I take my pen light and I shine it in their eye, what do you think is going to happen?
Nothing.
Not much, right? Does it look like it can constrict very much more? Really couldn't get much smaller, could it?
No.
No.
Do you think if it does change at all, do you think when you take the light out, being as how they are maybe overdosed on a depressant, do you think that those pupils are going to get back to the level they're at right now very quickly?
No.
No, that's because the central nervous system is under attack. We have a positive neurologic finding that tells me that there is something neurologically speaking going on and having negative consequences and negative results on this patient right here, just based on 2 seconds with a pen light. If we see a patient that has dilated pupils, we a lot of times, especially if they are fixed and dilated, fixed means they react not one bit when I shine my light in them. We generally associate that with cardiac arrest. If you have fixed and dilated pupils, you are probably working a code. Other things that will cause some pupil dilation are any type of,
Just a quick question. So someone like you were just explaining would be in cardiac arrest. Like at what point could we expect someone? So like if their eyes were like that, at what point, like what would they look like? What would the rest of them be like? Would they be able to talk, or at that point would they be completely just incoherent?
No, if you see fixed and dilated pupils, you've probably already figured out the whole cardiac arrest aspect of it.
Okay.
you would already be working the cardiac arrest because this is later on down the road. You know,
Okay.
so we'll get into our station one, right? We'll associate it with that. You know, you come in, Larry, are you okay? No response. Apply a little painful stimuli, Larry, no response. Okay, my patient's unresponsive. I'm going to check pulse and breathing for how long?
5 no more
5
than
to 10 seconds.
5, no more than 10 seconds. And I find no pulse, no breathing. Right away, we begin cardiac arrest management. I tell my partner to start CPR, and I start getting the defibrillator ready. So we've verified the cardiac arrest. We've begun compressions. We've begun the process of CPR. We're getting the defibrillator ready to administer a shock. And nowhere really in there did we talk about what the pupils look like.
Okay. So this is something that, you know, it's going to be a late thing. It's not something you're going to see before they're actually in full cardiac arrest.
Right. It's just another one of those things that, like, as you're working a lifeless patient, you might peel an eyelid open and look and see that the pupils are indeed dilated and really non-responsive.
Okay.
Because what we're really looking at is brain function. We're really looking at neurological function when we test pupillary response, and fixed and dilated pupils during a cardiac arrest points us in negative directions. So constricted pupils, we already hit that pretty good. We're talking some sort of central nervous system disorder or some form of central nervous system depressant use. So think things like opiates, even alcohol to a certain degree, but alcohol doesn't normally cause much pupillary change until we're talking ridiculous amounts and doses. We see inequality. Pupils really, unless it is a thing that the patient has had their entire life, should not be unequal in size after things like stroke or head injury or trauma to the eye. So if you see unequal pupils and the patient doesn't have a glass eye, but has just had some sort of head injury, some sort of trauma to the eye, unequal pupil size is not a good finding. And then last but not least, pupils that don't respond at all. Things like cardiac arrest, again, this could sort of fall in the dilated category a little bit, but these are just eyes that don't respond. We shine our light in it, and it does absolutely zero. Could be a lot of things, could just be something as simple as your patient has had some sort of eye procedure and they are on some form of drop that doesn't allow their pupil to expand and contract. So there's a lot of bits and pieces that go into this. And most of the time when we find things outside of the normal with our pupillary assessment and we shine that light in their eye and we don't get the constriction and dilation that we expect, it's generally not the greatest of findings, because the body does what it does to protect our central nervous system, to protect our brain and our spinal cord, and the eyes are connected directly to all of that, which is why this piece of our vital signs assessment can give us a lot of information.
Hi, I'm Josh Farquharson, and welcome to Blood Pressure Audio-Visual Coordination Skills.
So I'm going to let this play.
There are several steps involved in taking a blood pressure measurement, and each step must be completed with accuracy. This is especially true when viewing the blood pressure dial and listening with the stethoscope. You must be able to effectively coordinate what you're hearing with what you're seeing. Just imagine if you recorded a patient's blood pressure as normal, when in actuality, their pressure was extremely high and they were at risk for having a stroke. Your inaccuracy can have dire consequences on the patient's overall health. This lesson will help you achieve accuracy when taking blood pressure measurements. By the end of this lesson, you will identify and interpret the graduation markings on an aneroid sphygmomanometer dial, and determine the systolic and diastolic blood pressure by reading the dial and listening to the Korotkov sounds. If you ever had your blood pressure taken, you likely noticed that the results were stated as one number over the other number, such as 120 over 80. The number on top, in this case 120, represents systolic pressure, and the bottom number, in this case 80, represents the diastolic pressure. Let's take a close look at the dial used for determining such a measurement. This is the aneroid sphygmomanometer dial, also known as the blood pressure dial. The dial has the letters mmHg because blood pressure is measured in millimeters of mercury. Also on the dial, you'll notice that there are lines in various sizes. The largest lines represent values of 20. This is 20, this is 40, 60, and so on. The medium lines represent values of 10. This is 30, 50, 70, and so on. And the smallest lines represent values of 2. So this line represents 22, 24, 26, 28, and so on. Now let's use the needle to determine the number displayed on the dial. Concentrate on the tip of the needle and the line that it's pointing to. How much does this line represent? If you stated 68, you are correct. So how much does this line represent? If you stated 112, you are correct. And how much does this line represent? If you stated 294, you are absolutely correct. Great job. Now that you're comfortable with reading the blood pressure dial, let's apply audiovisual coordination skills. And for this, please increase your volume level and have a pen and paper on hand. There are two main areas that you need to focus on when determining a blood pressure reading. One, the position of the needle on the dial, and two, the Korotkov sounds. We will refer to the Korotkov sounds as thumping sounds for the duration of this video. When you arrive at the point of the procedure, when you slowly deflate the cuff to hear the sounds, you will notice the needle move in a counterclockwise direction. It is at this point that you need to listen very closely for the thumping sounds. Upon hearing the first thump, note the needle's position on the dial and record the number. That's the systolic pressure. As the cuff deflates and the needle continues to move, you will continue to hear the thumping sounds. Listen closely for the last thump. Upon hearing the last thump, note the needle's position on the dial. That's the diastolic pressure. Let's practice applying these two steps. Please note that your answer may be slightly different from what's displayed, but that's okay. As long as your answer is within 4 millimeters of mercury, your answers are still considered accurate. For example, if the displayed answer is 120 over 80, but your answer falls somewhere in the range of 118 over 78 through 122 over 82, your answer is still considered accurate. Of course, matching the displayed answer is the goal to achieve the most accurate answer. We'll use 114 over 76 as an example. All right, so now that you know the basics, let's try a few simulations. Listen closely and write down your answers. I will reveal the correct answer once the simulation ends. Here's the first one. Try another. Okay, and let's try one more. So, did you answer all of them correctly? Great job. Give yourself a huge pat on the back for a job well done. There's so much more to learn about blood pressure, especially when it comes to the terminology, ranges, and the many steps in.
All right, so I let that play for a couple of things. I know we've been working on blood pressures for all of last week. But it really did do a really good job. You know, in the middle when it got really, really loud, it was a bit played up. But the initial when we first heard those Korsakoff sounds come back, and the very beginning where you finally got that systolic blood pressure, that's pretty close to accurate to sort of how it sounds with the blood pressure cuff and the stethoscope when we're doing it in class. And the same as when it gets down to the diastolic, you know, we were really sort of tailing off and getting quieter and quieter, and it really, I think, did a really good job at that. It also gave us a pretty good visual of why I say watching and waiting for that needle to twitch isn't really going to help you a whole lot, because it's entirely possible that you completely missed the systolic blood pressure at that point, and it really doesn't give us really the most accurate of readings. And even at the BLS level, there are medicines that we can and can't give depending on what our patient's blood pressure is, and it really is on us to be right. All right, so here's where we're going to get into talking about some of our monitoring devices, and we are just about done lecturing on vital signs. I think, sure, tools that we can use to make our job easier are good as just that. They are tools that we can use to make our job easier. We cannot rely on these things. We talked on either Thursday or Friday, I don't remember which, about what happens when the machine that we're using to measure something and what the patient is telling us don't mesh. Something like when I put this pulse oximeter on my patient's finger, and it is telling me that my patient's pulse oximetry reading is normal, somewhere between 94, 95, and 100. But my patient is telling me that they are short of breath and they're having a difficult time breathing. And which one's right? Is the patient right? Is the machine right? Well, the patient is always right because we treat patients, not machines. The same can go for our blood pressure cuff, the automatic ones that maybe you'll use, maybe you won't. Facts being what they are, we need to take our initial sets of vital signs manually, because if we just take that machine at face value, we never actually know, is it right, is it wrong, is it somewhere in the middle? We never know that something's broken until it actually doesn't work. And how would we know that it wasn't working if we didn't have an actual physical manual blood pressure to compare that to, if we didn't have an actual physical feeling of my patient's heart rate, if we didn't do our respiratory assessment and get their respiratory rate and check for rate, rhythm, and quality, make sure that it's noiseless, effortless, and painless, because in the realm of pulse oximetry alone, it can be affected by almost anything. If your patient is in shock, if your patient is too cold, if your patient is too hot, if your patient has been exposed to carbon monoxide or any one of a number of other poisons, if your patient's moving around too much, if your patient's anemic, if your patient is wearing the wrong color nail polish, I can keep going. So we should never hang our hat on O2 saturation being the be all and end all. It is a tool. It is something to go along with your patient assessment, much the same as if you do have access and are okay to use automatic blood pressure equipment. Sure, great, makes life easier, frees you up to do any one of a number of other things when you're caring for your patient. But what I'll tell you is if you didn't take your initial set of vital signs and didn't do all of those initial steps of your assessment manually and observe them with your own hands and your own eyes and your own ears, you're wrong. Because you have no idea, does that machine need to be calibrated? Does that machine need batteries? Was it dropped on the last shift? And is this going to give me an accurate number? I know for a fact you guys can obtain an accurate number, but can the automatic blood pressure cuff and the O2 saturation? Not necessarily. Now, the last little bit of monitoring tool we're going to talk about is blood glucose monitoring. Anytime you are working with or treating a patient who has any form of altered mental status, you should obtain a blood glucose measurement. It doesn't always tell us what's wrong with the patient, but it does allow us to rule things in and rule things out. As you can imagine, a lot of medical problems and a lot of different complaints can present in the same fashion. When we talked about energy creation and how most of the spots in the human body will switch from that aerobic to anaerobic metabolism. Do you remember what I told you about the cells of the brain?
They feed off of sugar and oxygen.
Right, they feed off of sugar and oxygen, and they absolutely will not switch to that anaerobic metabolism. So 2 things that you can rule out right out of the gate for altered mental status are, does my patient not have enough sugar, and does my patient not have enough oxygen? So if your patient has an altered mental status and they're breathing appropriately and we have good rate, rhythm, quality, it's noiseless, it's effortless, it's painless, you can take 10 seconds to check your patient's blood sugar, and you can also check something else off the list. You can obtain a patient's blood sugar and figure out, is their blood sugar normal? Is their blood sugar high? Is their blood sugar low? Because anything other than normal could be what's contributing to their altered mental status. And it took you 10 seconds tops to figure all of that out.
So that's something we should definitely consider using in our practice, is on a regular basis of checking vital signs.
Absolutely. Now, it is not something that you need to check as a vital sign for every single patient.
Correct.
It is something you should use as a vital sign for people with an altered mental status and patients you know to be diabetic.
Okay.
Just because it is a best practice. You know, for a long time, it was included as a vital sign for everyone. And we figured out that we were just running around poking holes in people for no reason, because most people's blood sugars are normal. You need to either be diabetic or have some form of blood sugar problem in order for your blood sugar to be messed up. The reason I say check it on everyone is because patients who are having, you know, continuous seizures can have problems with their blood sugar when they wake up. And diabetics can present as drunks, they can present as people having strokes, it can mask a whole lot of other issues. So if you have something that you can concretely say, all right, I know my patient's a diabetic and I know they're acting altered, and you know, you start chipping away at what's going on with them, but you can also say, yes, but I also know that their blood sugar was 110, which is right dead smack in the middle of what we consider normal. Is it really their blood sugar that's making them altered, or is it probably something else? probably something else, right? Because their blood sugar, you measured it, it is spot on normal.
Thank you.
No problem. All right, that is it for measurement of blood sugar. I mean, not blood sugar. You got blood sugar on the mind, apparently. Measurement of vital signs. Anybody got any questions? So that actually kind of gives us an idea of why we measure them and why they are so important. What we have left for today is going to be how to actually perform a medical assessment. It's been just over an hour, so we're going to take a break and give you guys 15 minutes. And when we come back, we'll knock out the last lecture and we'll see where the day takes us from there, all right? All right, everybody, we're back. You guys back from break?
Physically or mentally?
We'll go with physically. It is a Monday morning after all. I'm not looking for
You know it.
my feet hit the deck this morning and it was all I could do just to make it to the kitchen for my first cup of coffee. I have no delusions that Monday mornings are good for people. So here we go, medical patient assessment, part number 4, chapter 9. We're going to talk about how we are actually going to accomplish all of the bits and pieces of figuring out what's going on with our patient. So assessment of a medical patient is a lot of verbal assessment. So if we look at the very top of this page, we see our scene size up, we see our initial assessment. So we're going to make sure the scene is safe. We're going to get our BSI or PPE on. We're going to start taking a look at mechanism of injury versus nature of illness. Today we're going to talk about nature of illness. We're going to determine how many patients we have. Do we need any additional resources? And especially on our trauma patients, we'll start thinking, do we need to pay some close consideration to cervical spine immobilization? All right, that's all well and good. Nothing's changed there. Our initial assessment, nothing's going to change there either. Our scene size up and our primary assessment are always going to be the same. Our primary assessment, we're approaching now, we see our patient, we're getting our general impression. Do they look and present to us how we expect people to? We start doing our mental status. Are they alert? Are they responding appropriately to the environment as we're getting close to them? We start making sure that they are just able to speak to us normally. That will tell us alert. If not, do I have to yell, Larry, to get him to open his eyes and look at me and pay attention to the fact that there's a stranger standing in front of him? If yelling at my patient doesn't do the trick, I'm going to pinch him. And if pinching on that trapezius muscle doesn't get me any response, I'm going to say Larry's unresponsive. On top of that, I'm going to go with, is he oriented now? Person, place, time, and event. So once I get my mental status under control, I'm going to assess for my life threats, any major bleeds, any airway compromise, any breathing compromise or problems with oxygenation. And then do I see or notice any circulatory problems, including, is my airway open, clear, and secure? I'm going to look at breathing, rate, rhythm, and quality. I'm assessing for painless, effortless, and noiseless. Circulation. I'm going to check pulse, rate, rhythm, and quality. I want to know too fast, too slow, just right. Is it regular or irregular? And what does it feel like? This is also where I take the back of my gloved hand and check skin color, temperature, and condition. And then last but not least is I do my sticky test. I take my hands and I stick them under my patient to see, do I find any blood that's being hidden by clothes or the fact that they're laying on the ground? As soon as I get to this point, I identify my patient's priority and make my transport decision. Larry's going to be a high priority transport to the closest appropriate facility with an ALS intercept en route. Easy peasy. That's going to be the exact same for our medical patients, our trauma patients, and anything in between, any combination thereof. Scene size up and primary assessment never ever change. Scene size up is what keeps me safe. My initial assessment, my primary assessment is going to be what keeps my patient alive and doing well. And today we're going to talk about this side and this side only. Our focus history and physical exam. If my patient is responsive and they're able to speak to me, I'm going to ask them a lot of questions about their medical complaint, so their nature of their illness. And in that green box in the middle is my sampler and my OPQRST. Sample is going to tell me a lot about my patient's past. So that's sort of my patient's medical history. The OPQRST is the history of their present illness. It's telling me what's going on with the patient right now. It explains to me in great detail all of the things that they are feeling and what is going on inside of them with their current medical complaint. Once I get to the end of that, I do an ongoing assessment. I take my baseline set of vital signs. Then I reassess any of the things that I've done or any of the problem areas that I've found and treated during my assessment. I do another focused assessment. I ask them the same questions over and over again because I'm still trying to identify a trend. Is my patient's condition improving? Is my patient's condition getting worse? If they tell me things that make me think that it's getting worse, well, then it's getting worse. If I've supplied some form of treatment and it seems like my patient condition is improving, well, God save the Queen, my patient condition is improving. And what I've done to try and make them feel better has actually worked. So that's for my responsive patient. My unresponsive patient is the exact opposite. If my patient is unresponsive, we're going to focus on things that I find physically. This is one of those patients where, checking out their respiratory rate and checking their pupillary response and figuring out, are there signs and symptoms that point me towards, hey, maybe this is an overdose. Hey, maybe this is an allergic reaction, based on things I find on my patient's body, is going to tell me a lot of information because my patient's unresponsive and not telling me any. Do you find things on your unresponsive medical patient like medical alert tags or insulin pumps or that little box that we saw underneath the skin during our CPR class that tells me, hey, my patient's obviously got some sort of cardiac history because he's got an internal either pacemaker, defibrillator, or both? My secondary assessment is when I start asking all these questions and start doing my patient assessment outside of the primary. So once we've gotten through airway, breathing, circulation, and my transport decision is when I start really peppering this patient with questions. And once I get to the end and run out of questions to ask them, I'm going to do a focused physical exam. If my patient's complaining of chest pain, my focused physical exam is going to include all of the things that are in their chest. So I'm going to look at their respiratory status a little bit more closely. I'll ask them if they have any trouble breathing to go with their chest pain, things like that. Because any body system that is associated with their chief complaint, which is the thing that is bothering them the most, I need to take a look at when I'm doing my patient assessment. I don't need to ask them, does this little toe hurt, when they're complaining to me about 10 out of 10 crushing substernal chest pain and respiratory distress, because I don't imagine if their toe being painful to them is in any way related to the fact that they are having crushing substernal 10 out of 10 chest pain and difficulty breathing. I get to the end of asking my questions and doing my focused physical exam, and I get a set of baseline vital signs. That's my first set. It is going to pull everything together and tell me what's going on now inside of my patient. Remember, this is an outside look of what's going on inside. When I'm speaking to my patient, I can get information from them. I can get information from family or bystanders, but I want to make sure I ask open-ended questions that allows my patient to answer in their own words. What do I mean by open-ended questions?
Get them talking about how they're feeling.
Yeah, don't ask things that can just be answered in yes or no fashion, because one-word answers give me no information. Do you have chest pain? Well, they're going to say either they do or they don't. But if you already know, based on your chief complaint, that they're having chest pain, how about what does your chest pain feel like? Because just saying, again, yes, I have chest pain, doesn't tell me much. But if they tell me it feels like a stabbing pain, it feels like a burning pain, it feels like a squeezing discomfort in their chest, that gives me a whole lot more information to try and base some of my decisions on. The other part of open-ended questions is don't ask them questions in a leading fashion, because patients, a lot of the times, especially if they're nervous at all, or if they're really sick and just don't feel well, they will tell us anything under the sun that they think we want to hear. So if I say, do you have a stabbing pain? Do you have a burning pain? Do you have a squeezing pain? We're going to get to the end of that line of questioning, and they're going to have said yes to every single one of those. So just ask them questions that allow them to answer is really that sort of open-ended bit right there. Our chief complaint could be different from the reason we got sent out. Our chief complaint is going to be what is bothering the patient the most. You know, we could get dispatched for just a sick person. And I can honestly tell you the amount of times I've been dispatched for sick person and shown up and just had a patient tell me their chief complaint was, well, I'm just a sick person, is zero. Their chief complaint is just that. What is the thing that you could point at that is bothering you the most that made you call 911?
Question, Tommy.
Shoot.
So you get it to a patient of a call. He says, you know, his head was hurting, but then you show up and you realize, like, which would be the chief complaint, but you realize, like, his ankles turned 180 degrees. Would that switch to be the chief complaint?
It would depend what he told me. Because if the patient is still complaining that their head is hurting them,
Yep.
but I have feet and stuff pointing in wrong directions and clearly fractures and dislocations and all sorts of angulated stuff going on,
Yep.
That's got to be one mother of a headache.
That's true. Good point.
You know, and if that is still what is bothering that person the most, yikes.
That stays the chief complaint.
So Tommy, maybe I could be wrong, but I think maybe what Alex was kind of asking, because now I'm curious. So is a chief complaint based on what the person's telling us instead of what we're finding? Because let's say, like he said, the ankles at 180 degrees shouldn't be that way. So would it be possible that they're in shock from that and they're complaining about something else, but they're all just discombobulated because of what the injury's done to them?
Oh, absolutely.
Yeah, that's kind of.
And realistically speaking, shock will do that. And clearly that ankle still requires, some of our attention. And, it could be something as simple as, hey, how did your foot get like that? Oh, well, I stepped in a hole, my ankle blew up, and I fell and hit my head on a rock. And okay, fine, they got a big lump on the side of their head. And, all right, did you have any loss of consciousness? No, I didn't have any loss of consciousness. Do you remember the incident? Yeah, I remember clearly. I stepped in a hole. I heard a loud explosion. When I pulled my leg out of the hole after I whomped my head on that rock, I noticed my foot was pointing backwards, but boy, does my head ache. Sometimes the body, when it goes into shock, it's only going to accept a certain amount of pain. It will physically actually block some of that pain impulse. And a lot of times those real significant fractures don't always come associated with a whole bunch of pain based on the fact that nerves are compromised and just the body goes, yep, nope, not dealing with that. And the chief complaint could be something different from whatever the biggest problem is. But the chief complaint is still that. The chief complaint is whatever the patient tells you is bugging them the most. Now, most of the time with our medical patients, the chief complaint does point us towards what the actual problem is. With our trauma patients, sometimes it can be a little different because we can find things that are all smashed up. And just based on the fact that their body is going into shock, their complaint could be almost nothing at all because of the decrease in sensation or just the increase in epinephrine, making them, Superman. So I think that probably answered your question a little better, right?
Yes, thank you.
No problem. So sticking with assessment of our medical patient, we're going to obtain the history of our present illness. This is the beginning portion of our secondary assessment. So we've done the primary, we've done, general impression, level of consciousness, airway, breathing, circulation. We've made our transport decision that there are high priority transport to the closest appropriate facility with an ALS intercept en route. And now we're getting into the meat and potatoes here of what is going on with their current illness. So the OPQRST is just what you see here right on your screen. Onset. What were you doing when it started? How did all of this come about? How a problem presents to the patient can tell us a lot. My patient who hasn't been on a treadmill since he graduated high school 22 years ago and just decided to take up a strict exercise regimen and decides they're going to hop on the treadmill and get to running. And about 2 minutes into their trip on the treadmill, they developed some chest pain and sat down and called 911 because they were having chest pain. All right, well, at least that chest pain has a reasonable beginning, right? That cardiac muscle wasn't used to having to put out that kind of demand. It was needing more oxygen. It got a little cranky. My patient who was just sitting on the couch, minding their own business, and then bam, out of nowhere, bingo, chest pain. That tells me something a little different. There was no increased demand. There was no aggravation to that cardiac muscle. There was no excess need for oxygen. And now all of a sudden, chest pain just smacked this guy in the face out of nowhere. All right, well, that tells me something a little different too. After we answer our onset question, how did it start? What were you doing when it started? We move on to P. P is provoke or palliate. Does anything make this pain better or worse? Our person who was just on the treadmill after 22 years of inactivity. They're probably going to say, yeah, when I was on the treadmill, my chest pain got worse. When I sat down, my chest pain got better. Versus your patient who was sitting on the couch minding their own, really nothing makes it better and it just keeps getting worse. Okay, well, they're still not doing anything to aggravate it, and it's continuing to build. It's continuing to get worse. Quality is where I get the what it feels like. Can you tell me what it feels like? Describe the pain you were feeling. Tell me what your discomfort actually feels like, because this isn't always just limited to pain. If we're dealing with somebody who has a respiratory complaint, they a lot of times won't have any complaint of pain, but then I say, all right, well, tell me what your difficulty breathing feels like. And they'll say, oh, my chest feels so tight, like I can't get a deep enough breath in or out. and I'll hear wheezes, and I'll start thinking, all right, does this patient have asthma? And it will start now leading me towards what could possibly be wrong with this person. After we get through our quality, we're going to start thinking about radiation. Where is the pain, and does it go anywhere else? Does the pain that you're feeling or the discomfort that you have stay in that one spot, or can you feel it other places too? S is pretty straightforward. How bad is it? On a scale of 1 being no pain at all, 10 being stepping on a Lego in the middle of the night, how bad does this feel? And then last but not least, in the history of our present illness assessment, we want to know, when did it start? How long has this been going on for? So, does everybody see the difference between onset and time? Because sometimes that's a tripping point. So onset, what were you doing? How did it come on? Fast, slow, sitting on the couch, running a mile, jumping rope, doing something crazy. Time is just how many minutes? Plain and simple. How long in a measurement of time has this been going on for? Everybody still with me so far?
Yeah, seems pretty straightforward.
And that's the reason it's laid out like this, because it seems, especially looking at the sheets that Kevin gave out to you on Friday, did anybody look at those sheets and go, holy Christ, there is a lot of stuff here?
Yep.
Yeah.
Right. But if you start breaking things down and look at it as like logical progression, one thing leads to the next, and everything is laid out just so that you don't miss anything. You know, this OPQRST, it asks all the important questions with only 6 questions. And it leaves it completely not up to debate whether you got all the important information or not, because it's all pretty well front-loaded into this. So that was our present illness. When we talk about past medical history, also pretty straightforward, and they give us another handy-dandy mnemonic as an effort to try and get it sorted out. It's sampler. So we're looking for signs and symptoms. Signs are things that I can see: skin color, temperature, condition, increased respiratory rate, increased respiratory effort. Those are all things that I can visualize and see on my patient. Symptoms are things my patient is going to tell me. Symptoms are things that my patient is feeling or noticing about themselves that are going to tell me a little bit about what's going on. So signs are just like a stop sign, something I can actually see. Symptoms are something that are reported to me. I want to know if they have any allergies in their medical history. Are you allergic to any food, medicine, or anything at all? Allergies aren't always super duper important to me in my work in the field, because there's not a whole lot of medicine that I'm going to give that people are going to be deathly allergic to. But who might their allergy history be very, very significant to?
Doctors at the hospital.
Doctors at the hospital, paramedics who have like 65 different meds that can kill people. Anybody sort of downstream and responsible for their ongoing and really definitive are going to want to know why they have what they have for allergies. Equally as important is what they take for medications currently. The other piece of what do you take for medicines are, do you take them appropriately? Do you take them as prescribed? Especially with the elderly people, sometimes this becomes a bit of an issue because medicine's expensive. And there are times where elderly folks will have to make the decision between taking their medicine as prescribed or putting oil in their oil tank or putting food on their table. So what do you take for medicines? What's prescribed for you? What do you take over the counter? And do you take them the way that you're supposed to? Next, I'm going to ask them about their pertinent past history. If I'm at Nana's house and Nana is older than time, I don't really need to know that in 1958, old Doc Johnson came to the house and took out all the kids' tonsils. But I do need to know that Nana had a heart attack or a stroke 6 months ago. I need to know things that are pertinent to what's going on right now. When we get a little bit past all of this stuff and I'm doing my ongoing assessment and sort of rapport building with my patient, if she wants to talk to me about, anything under the sun as far as medical history goes, I will be happy to entertain that discussion. But at this point in time, it's all about business. And I'm at the business right now of figuring out what's going on. So I need to know pertinent past history. The L in my sample is last oral intake. Really last ins and outs. When is the last time you had anything to eat or drink? When is the last time you used the restroom? These are important questions, but they are not things that we need to go too deeply into. Ask them when was the last time they had anything to eat or drink. Ask them when the last time there was that they used the bathroom. And unless they give you something wild as an answer, it's just another piece of the puzzle. This is not something that is super duper important. I'm looking to know the events leading up to the illness. This is also pretty sort of hand in hand with the onset, right? Some of these questions are just posed, the same question posed in different fashions, just to make sure the patient is understanding us and make sure we're getting the best information that we can. And last but not least, I'm going to look for any risk factors, things that may have come up in their past history, like recent heart attacks or a history of high blood pressure and non-compliant with medicines, someone who smokes or drinks or does drugs or has a family history of, oh, nobody in my family's lived past the age of 40 without having a heart attack. And here they are 42 with whopping chest pain. Okay, well, again, 2 + 2 being 4 and all, we start to think maybe this patient's working on their first cardiac event. Some of these are kind of strange little bits that we ask these folks, though, aren't they? Last oral intake, things like that. Why do you think that's part of what we're going to ask the patient? Why do you think a lot of these questions and a lot of their medical history are things that we go poking into?
Some medication shouldn't be taken with alcohol. So if they had an oral take of like a beer with their medication, it could affect them.
Okay, so if they're following the labels, I like it. Think about who might be the last person that gets to talk to this patient.
You.
Probably you, yeah.
It could be you. You might be the only person that gets to talk to this patient. You could drop them off in the emergency room and they could go unresponsive. And the doctors and nurses and surgeons and whoever else is going to see, evaluate, and treat this patient has no ability to get any information from them other than what you've already asked them and what you provide for them. So making sure that we get the answers to all of our questions here, is going to be really, really important. Some of our secondary patient assessment is fluid, right? We can ask questions. If our patient's not understanding us, we can rephrase those questions. We're really trying to tailor our assessment to get the best and most information we can. We want to make sure we're appropriately evaluating their chief complaint, which is why I say I don't care that you had your tonsils out 70 years ago. We'll talk about that in a few minutes. That's my internal dialogue. Sure, I'll be happy to talk to you about that, but tell me more about your chest pain. We're going to ask questions that are pertinent to that complaint to try and make sure we don't get lost in the weeds. We do a body systems approach. We want to look at the body systems that are most likely involved with whatever our patient's complaint is. That's why I say we're going to assess whatever it is that they're telling us. So if they're saying crushing substernal 10 out of 10 chest pain, obviously I'm starting to think cardiovascular in nature. I start thinking of cardiac causes for this. But in assessing my cardiac causes, I'd be crazy to ignore the fact that the cardiac and respiratory systems are both pretty well connected. And I'd also be kind of crazy to ignore the fact that if they have some form of cardiac compromise and they're not effectively circulating blood appropriately because their heart muscle's not doing so great, what are some other things that could be affected? If they're not delivering blood effectively, they're not delivering oxygen and sugar effectively, we need to make sure that we're not missing things like maybe subtle changes in their mental status, you know, slowing down a little bit or getting confused a little bit easier. You know, these are all the things that we pick up on throughout our assessment, which is why when we get to the end of that OPQRST and that sampler and we get our baseline set of vital signs and we provide some form or fashion of treatment, whether that's actual medication or whether that is transport to a receiving facility, we go right back to the beginning and we rewind it right back and run the whole thing again to now compare what they're telling me now to what they told me previously. I compare my primary assessment, I compare the way my patient is responding, and it is all just more trending. Is my patient getting better? Is my patient getting worse? Or at very least, hopefully, my patient is staying the same. That's all if my patient is able to speak to me. If my patient is unresponsive and unable to communicate, okay, that's great. I can't focus on the chief complaint. I can't really focus on history taking. That's all well and good. All is not lost. I go into medical detective mode a little bit and I perform a physical exam. When we perform a physical exam on a patient, we do it in a head to toe fashion. If you're performing a physical exam on a patient and poking and prodding and touching and listening to things, we start at the head, excuse me, we work to the toes, and we look at and touch and poke and prod everything in between. If you do it in that systematic fashion and just go one piece to the next, to the next, to the next, to the next, you can't miss anything. It's difficult to get information from somebody who's unresponsive, even with an appropriately done physical exam. But what you can do is work through the progression, do your assessment in that very regimented fashion. And when you get to the end, you get your set of baseline vital signs. And at least you know you won't have missed any glaring things like a cardiac defibrillator in the upper right portion of your patient's chest, or a medication patch, or crappy lung sounds, or weak thready pulses, or a patient who's extremely hypotensive with a respiratory rate of 6. You know, it's more difficult to get information when there's no back and forth with the patient. They can't talk to you about their chief complaint. You can't get any history. You don't know them from Adam. And at the end of the day, all you can do is look for clues. And if you find them, that's great. And if you don't, we treat what we see in front of us. We get our set of baseline vital signs and we do what is in the patient's best interest most of the time. And we take care of their ABCs and we transport. Unresponsive patients are difficult because there's absolutely nothing we can do to get in the information. Our unresponsive medical patient is very similar to the assessment of a trauma patient. We're still going to get information from family and bystanders if we can, and we do a rapid assessment of the entire body from head to toe. When we look at certain areas on our patient who is unresponsive and of a medical variety, so someone we know was not involved in any sort of traumatic event, we assess the neck for jugular vein distension. So that's those big engorged veins on the side of the neck. We're going to look for any medic ID necklaces or anything like that. When we assess their chest, we're going to listen closely to their breath sounds. That could point us in a direction of some form of respiratory cause of their unresponsiveness. When we assess their abdomen, we're going to press and palpate all 4 quadrants of their abdomen. We're going to inspect it for distension, any firmness, any rigidity. When we look at their pelvis, we're going to see if they were incontinent of any urine or feces. That can tell us maybe the patient had a seizure. That can also let us know maybe how long they've been in this state for. When we assess pulse, motor, and motor function and sensation on our extremities, we're also going to start looking for medical ID devices, so medic alert tags or rings or anything of that nature on our patient. And really, once we get to the end, we get our baseline vital signs. Any patient who's unresponsive, it's really protocol to start looking for an intercept or getting some form of ALS personnel headed out to meet you. And we transport. If your patient can't talk to you, does it make any sense to spend any extra time farting around on scene, waiting for them to just rise up and start answering questions?
No, you got to work with what you got and you got to keep it moving.
Absolutely. I love it. Work with what you got and keep it moving. As long as we always go right back to our primary assessment and start from our primary assessment and work soup to nuts from primary assessment through our secondary assessment again and reassess our vital signs, you're going to find all of the things that you're able to, and you're going to not miss any opportunities to treat this patient, unresponsive or not, appropriately. If our patient's unresponsive, we rely on family and bystanders a bit more. Try and get the patient's name. Try and get information from them about what happened. Did you see or notice anything else about this person? Before they went unresponsive, did they complain about anything? Oh yeah, now come to mention it, Grandpa had spent all day on the couch, which is very uncharacteristic, complaining of this awful, awful headache. And then when we came back 15 or 20 minutes later, we couldn't wake him up. Okay, keep that in the notebook because that's significant. Try and get as much information about this person as you can because they're never going to give you any. Talk to anybody who will talk to you. Find out what you can about their medications. If you're in somebody's house, and I don't know why this is, but it seems like every house in America, the medications are always on top of the microwave. So while you're doing the assessment, your partner can go off and get a medication list. We can start putting together some of the pieces for when we transport to definitive care. Our assessment of an unresponsive is limited. It just is. There's not much that we're going to get for information. There's not much that we're going to be able to do. But we should definitely start looking into what the family and bystanders have to say, what other things could be at play. Oh, well, he was prescribed this new medicine And he complained he felt a little woozy after he took that medicine. And now this is how we found him. Okay, what was that medicine? What was it for? Oh, as far as high blood pressure. And then you all of a sudden take grandpa's blood pressure and his blood pressure is like 60/40. If it looks like a duck and it sounds like a duck.
Question, Tommy.
Shoot.
Shooting into a situation where you find a patient, and you go look inside their house for their medications, 'cause someone tells you, they take medications, and you see a nice bowl that looks like a candy bowl mixed of all kinds of goodies. Is it appropriate to take pictures of finding certain things that could be helpful of any reason to like the doctors?
So when you mean candy bowl full of goodies, you mean a candy bowl full of pills?
Yeah.
Would I take a picture? No. Would I document it? Yes.
Okay.
There's a part in the book. Now, remember, I'm going to give you guys bits and pieces here, book versus the best practice for your patient, right? The book is going to tell you to take all of your patient's medicines, put them in a bag, and bring them to the emergency room with you. And what I will tell you is, in practice, those will get lost or thrown away. So what won't your patient have when they're discharged back to their home?
What won't they have?
Yeah,
Their medication?
their medication. And anybody out there that's familiar with the way insurance companies work, they are not super happy about sending more medicine because you lost yours or it got thrown out or something happened to it. Get a list. I understand, and the book is going to tell you different, and I understand why the book says bring them with, because the hospital can look at, when was this filled? Have they taken enough? Have they been taking these appropriately? But it's a difficult game to play. If you bring your patient's meds with you to the emergency room, make sure you give them to someone responsible. Hand them to the nurse that's going to be taking care of this patient. Because things that just get left in the emergency room with the patient, a lot of the times wind up not making the travel throughout the hospital with the patient and wind up in a garbage bin somewhere.
Okay. Thank you.
Yep. Once we're done with all of our bits and pieces of assessment, we compare them. We keep going back and forth. We get to the end, we start back at the beginning. Because the primary assessment is where everything begins. The primary assessment is where everything loops back to, because the primary assessment is what keeping that patient alive right now. No open, clear, and secure airway, patient's not gonna be in good shape. Patient who's got an inadequate respiratory rate, rhythm, and quality, we're gonna have a patient that's in some tough shape. Patient who's not circulating blood appropriately and bad rate, rhythm, and quality there, our patient's going to be in tough shape. Doesn't matter if they're responsive or unresponsive. If we don't start back at managing those things and make sure they are at least as viable as they were when we met this patient, all of the other stuff we can do just falls by the wayside.